Okay, so good afternoon, everyone. Today's lecture will be on neurological system, and it's the pathophysiology of the alterations that affect the nervous system. And we start with chapter 15 about pain, temperature, sleep, and sensory function. We will focus on the pain and temperature, because the sensory function, which is the ear and eye problems, will be covered in adult health too. And I go always on the pathophysiology for alterations or pathophysiology of cataract, glaucoma, retinal detachment, and other eye problems. That is covered under adult health too. So just focus on, from this chapter, just on these two content areas, is pain and temperature. So pain, as which has been defined as unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So that was the definition according to the International Association for the Study of Pain. And we have other definitions of pain. What we found over the years is that historically we have too many theories to explain the nature and the pathophysiology of pain. And every time that we try to define pain, we find that we miss something, or something is missing. We couldn't capture all the aspects or all the contextually. We couldn't include everything in context, and and include the we miss some factors, we miss some features, we miss some elements from the full definition of pain when it comes to contextually trying to understand pain. So there are three systems that are they interact to produce pain. So when it comes pain threshold, pain tolerance, pain dependence, and so that's why we have as we defined later on these terms, you will find that the experience of pain involve the interaction of all these three systems. So I'm just for this slide is just to show you that the sensory discriminative system, which will process the info or information about the strength, the intensity, the temporal, spatial, in terms of space of pain, and the motivational affective system, which determines the individual's conditioned or learned approach, avoidance behavior. And another one, which are the third system, which is cognitive evaluative system, which takes into consideration the patient's experiences of pain. So that explains a little bit about why some people or patients would have a high tolerance, others will lower tolerance threshold, and dependence. So that explains the three concepts of pain, which is threshold, tolerance, and dependence. So the three systems interact, or the three systems interaction of these three systems will give us an idea about the pain experience. But the theories that will explain, give you a specific understanding how pain develops, or how pain, the pathophysiology of pain will explained by these theories. And so there's certain limitations with the theories. I don't want to spend much time on them. It's just to say that the specificity theory, it lacks some aspects of pain, pain experience. It doesn't, for example, this theory, it's useful for pain associated with specific injury and acute pain. But this theory, it doesn't take account for, or doesn't cover the chronic pain. It doesn't give us a full explanation about the chronic pain or cognitive and emotional elements that contribute to more complex types of pain. The pattern theory, it describes the role of impulse intensity and the restructuring of the central nervous system. But although the theory evolved to provide an explanation for neuropathic pain, this theory, it doesn't account for all types of pain experience. So there are limitations for the first theory, the second theory, the gate control theory, which is one of the oldest theories. So this theory developed to explain the complexities of the pain phenomena, but inadequate, which means that this theory wasn't providing adequate explanation about the chronic pain, or what is called the phantom pain, or we call it phantom limb pain. Who would be affected by the phantom limb pain? We call it phantom pain.
Amputees.
Right. So, but post amputation, patients experience something called phantom pain. They still can experience the pain as if they still have the limb and not being amputated or surgically removed. So that's the gate control theory. The gate control theory, I'm giving you some examples about like, rubbing of the pinch finger can reduce pain. And the last one, which is in the Neuro matrix theory, this theory represent the plasticity of the brain and provide the holistic integrated dynamic view of pain. So it kind of includes more aspects, more factors, more contextual coverage of pain experience than the other theories, especially when it comes to experience with pain experience, or like patients, living with, especially those who live with chronic pain, for example. So it takes all of these consideration of the genetic, the affective, the cognitive, evaluative, and other components that will be included in the understanding of the pain experience when it comes to the neuromatrix theory. So not much of emphasis on this theory, just to give you an idea that, we attempt to explain the pain experience. It's very multifaceted, it's very complex, and it's very complicated, and it's very comprehensive in terms of, when it comes to pain assessment as well. So the neuroanatomy of pain is based on understanding the different types of the nociceptors and the different types of fibers, which will transmit the pain experience. So nociceptors, which is the cells of the nervous system that are responsible for the receiving the stimulus, and that's will be activated, and that's where we will feel or have that sensation or the experience of pain. So pain transmission, which is the conduction of pain impulse along the A, delta, and C fibers. These are the two main fibers responsible for the transmission of pain sensation. They will transmit that to the dorsal horn of the spinal cord. And that table provides like an association between the location of receptor and the provoking stimuli. Examples of the provoking stimuli and how it will stimulate that receptor, and then the resultant effect would be a pain sensation or pain experience. Now, the nociceptors, they are the free nerve endings and skin, muscles. They are located also in the joints, arteries, the viscera, which is the internal organs. The two different types of fibers. The first one is the A delta fiber, which is the medium size A delta fibers. They are myelinated, so they are covered by the myelin sheath. And anytime you hear that myelin sheath, next to it, write down the velocity of that of the impulse, which is how fast the impulse will be transmitted along the fibers. So the absence of the myelin sheath, then that takes longer. And when we get to the like multiple sclerosis, patients with multiple sclerosis, they have problem with the myelin sheath cover, that covers the nerve fibers. So here with the pain experience, with the A delta fibers, they are covered with myelin sheath, and they transmit the sharp, well-defined, fast pain sensations. Like, for example, these are responsible for the causing the reflex withdrawal. When we, try to touch the hot object, automatically you will try to get your, your hand or your away from the hot object. So that is a reflex withdrawal, is usually activated by the alpha fibers, because they myelinate, covered with myelin sheath, and they transmit the sharp, localized, fast pain sensations. The smaller ones, which is the C fibers, they transmit the dull, aching, burning sensations. They are poorly localized and often constant, like patients who would have like a dull sensation. Sometimes it's constant. There's another type of fibers called the A beta. They are large, they are myelinated, so they are covered with myelin sheath, and they transmit the touch and vibration sensation. They do not, normally, they do not transmit pain. So the nociception, these are the sensory, which is the sensory process leading to the perception of pain. That's when we feel that pain, or the pain experience results from the activation of these nociceptors. So these nociceptors, they are present in the nerve endings in the skin, muscle, joints, arteries, visceral organs like internal organs, that will send, respond to the chemicals and mechanical and thermal stimuli. It can be hot object, can be like, sharp object. It can be trauma, force. All these would result, chemical, mechanical, or thermal, all will result in pain sensation because they are going to activate these nociceptors. So we talk about the A delta fibers and the C fibers, and what's the difference between them. It's this figure shows the how gate control theory of pain explains the experience of pain, like the large A beta fibers, non-nociceptor impulses, mechanical and thermal factors would activate them, and it will open the gate, and then it will result in a pain experience. The neuromodulation of pain, there's something called endorphins, right? So we have natural endorphins, which are naturally produced to block the gate control, or block the gate, so it will result in pain relief. So naturally, our body is able to produce something called endorphins. Because when you give the patient the opiates, which is the pain medication, that these pain medications, we have receptors. So the pain med is going to block the receptors and stop the pain. Another explanation or mechanism is that all endorphins attach to opiate receptors. So we have opiate receptors. Either your body produces the endorphins natural, which is very small, tiny amount. It's not going to be enough to cover or resolve the pain experience, but that's why we have to get receive pain medication. But all endorphins that are naturally produced from our body, they attach to the opiate receptors on the plasma membrane of the afferent neuron, and the combination inhibit the release of the neurotransmitters, what is called the excitatory. So that's excitation, which means it will excite. So when you hear that excitatory neurotransmitters like substance P, glutamate, somatostatin, the excitation of these neurotransmitters, which means producing these transmitters. So the excitation will result in pain relief. So substance P, one of them, glutamate, another one, and somatostatin. The inhibition of the neurotransmitters, which is inhibitory neuromodulation, that's going to result in more the excitatory, it will result in pain experience, and then the inhibition would result in the pain relief. So pain relief, the inhibition of the nociceptors, like by the glycine or serotonin or norepinephrine or endorphins. Like endorphins, one form of that natural produce that will do the inhibition, so it will antagonize the receptors. So the simple, I will say the simple or simplistic kind of concept of all of this is that we have neurotransmitters that are going to result in pain relief. Others would excitate or cause pain problem or sensation of pain. So the receptors, which is nociceptors, which is the receptors, when they are excited by the substance P or glutamate or somatostatin, that's going to result in pain experience. But when they are inhibited by chemicals like endorphins, then that results in pain relief. And that's exactly the mechanism how morphine and other pain medications and opiates function, or the mechanism of action is that they will inhibit, they will antagonize and inhibit the receptors. So they're going to bind to the receptors and do the inhibition. So the endorphins, there are different types of endorphins. Our body produces the enkephalins, dynorphins, endomorphins. All of these are natural pain relieving chemicals that our body produces to inhibit the neuromodulation. So inhibitory neuromodulation always equal pain relief. Chemicals produced to antagonize the receptors to relieve pain. Pain threshold, and we have something called pain tolerance. And in pharmacology, you will also learn about the dependence, which is not exactly like addiction, but it's two different concepts. But just try to differentiate between pain threshold and pain tolerance, because you cover, I believe, this content in Adult Health 1, and mostly will focus in Adult Health 1 on the assessment and treatment or management of patients, right, of pain, which is pain management and pain assessment and management. So pain threshold is the lowest intensity of pain a person can recognize. In other words, you can say the point is the lowest intensity at which stimuli is perceived as pain and may be influenced by genetics. And so that's the patient's threshold. And anytime that threshold is exceeded, then the patient will start sensing or feeling and experiencing pain experience. Pain tolerance, which is the greatest intensity of pain a person can endure, and duration of time of the or the intensity of pain that a person will endure before initiation of pain resource. Like let's say that patient is on a morphine 50 milligrams PRN as needed Q4 hours. Then the patient within like chronic, let's say chronic, with cancer patient, late stage, within 3 months, the patient at the same dose still is experiencing, started to, at the same dose, patient's pain started to go, to patient experiencing pain even with that medication, dosage, frequencies. So then we have to increase the dosage in order to cover the patient's pain because that pain tolerance. So pain tolerance is the greatest intensity of pain a person can endure. And that's also influenced by cultural perceptions, by expectations, like cultural in terms of cultural influences like male, female. Sometimes you see these kind of experiences in other, like in certain cultures, that the male is it's not culturally acceptable, socially acceptable for the male to complain of pain or to to even voice that they are suffering from pain. So cultural perceptions can have an influence of that pain tolerance. The gender, there is also gender differences, and in addition to the physical and mental health. It varies greatly among people and the same person over time, even for the same person over time, because the body's ability to respond to these nauseous stimuli, it's different from time to time. So it varies greatly among people and in the same person over time because of the body's ability to respond differently to nauseous stimuli. So the pain tolerance greatly would decrease with repeated exposure to pain. So the more, the longer the experience with pain, that tolerance is going to be going up. In other words, it will decrease. I'm sorry, it will decrease. So pain tolerance, it will decrease with repeated exposure to pain. Similar to what the example I gave with a patient who was is living with with liver and with cancer on morphine, 50 milligrams BID or Q4 hours, and then patients that's no longer is going to cover patients pain. So that we have to go a little bit higher because with the dosage because the tolerance decreases. So over time, the pain tolerance decreases with repeated exposures to pain, or due to either repeated exposure to pain, like patients with cancer, or with fatigue, or apprehension, or sleep deprivation, and the tolerance would increase with other factors like persistent use of opioid medications, and that's not the case as I give like patients with with cancer on morphine, or it will increase the tolerance. The pain tolerance will increase also with alcohol consumption. Some types of procedures or modalities called hypnosis, distracting activities, sometimes spiritual um, effect could increase the pain tolerance. So classification of pain, we classify pain as somatic, which is affecting through the skin. You feel that pain is more superficial. It's not internally coming from the organ, which is visceral. It could be non-nociceptive pain, like neuropathic pain. Like patients who are diabetic, they develop a neuropathic pain, peripheral and central. And patients, with PAD, peripheral arterial disease, they will also have both somatic and the neuropathic. The manifestations are listed here, and I'm pretty sure that you will cover that in the ductile 1, 2. Another classification of pain is acute versus the referred or chronic. Acute could be acute somatic, acute visceral, and the acute in terms of the duration and the time, how it's different from the chronic. Chronic, it's longer, it takes long term than the acute. Referred pain, which is the pain that is present in area removed or distant from its point of origin. In other words, that the area why we feel sometimes the patients will, for example, patients with liver, an example of this one would be like a patient with liver problem. Sometimes they feel a shoulder pain. So it's a patient had a liver problem, but they felt a liver pain. And one of the theories that would explain the referred pain is that the area of referred pain is supplied by the same spinal segment as the actual site of pain. So there is something called conversion in the neurovascular system. So the impulses from cutaneous, which is from the skin, and the visceral neurons from the internal organ, the impulses from these two sides, in cutaneous, skin, and the visceral, internal organ like liver, they converge in the same ascending neuron. And the brain cannot distinguish between these two impulses. Because of that convergence, or that these two impulses will converge in the same ascending neuron, then the brain cannot distinguish between these two, then you will feel that what is called referred pain. Same thing with acute myocardial infarction, acute MI, right? Patients with acute MI, they will feel that, and you have it here, right? Acute MI, they will have a pain, numbness and pain on the mostly the left arm. And that's also a referred pain. And there are other examples of referred pain, but that's the pathophysiology behind the referred pain. The chronic pain, we said it's related to or due to the damage or inflammation to the tissues or injury of the nervous system. And usually it lasts, in terms of the chronic pain, usually defined as lasting at least 3 to 6 months. Then we can call it chronic pain. And the common types of chronic pain, like patients with myofascial pain syndromes, they experience spasms, tenderness, stiffness. Cancer pain is another form or another type of chronic pain. Post-op, not usually the norm. It's always acute unless it stays for longer than 3 or 6 months, then that becomes chronic post-op pain. And high likely that, that could be from the buildup of the of the tissues or of the the abnormal tissues, and the adhesions, like something called adhesions post-op. The buildup of these adhesions, it could result in a chronic pain over time. The neuropathic pain You will see this in patients with diabetes, for example. Diabetic neuropathy is a form of neuropathic pain in patients with diabetes, and that's will be treated differently than um, the acute or chronic pain. Patients with neuropathic pain will be treated with a anti-epileptic drug called, which is one of the most effective drug called Neurontin, gabapentin. Gabapentin, which is a Neurontin, it's one of the best medications to treat neuropathic pain, and it's not the primary use or labeled use. It's the off-labeled use because it's an anti-epileptic, it's an anti-seizure drug. But what they found from experience that it's also can relieve the neuropathic pain from its mechanism of action. It's effective to treat neuropathic pain. So it's an off-labeled use because it's the anti-epileptic drug or what is called the anti-seizure drug. So that's an example of the neuropathic pain for patients with diabetes. You'll find them taking the Neurontin, which is a gabapentin, and you can tell that they are taking that not they are not receiving the medication because they have an epilepsy or seizures. It's because they have a neuropathic pain from diabetes, and it will relieve the neuropathic pain. Central pain, an example of that would be the phantom limb pain. Phantom limb pain, which is pain experienced post amputation. Patients still can feel that pain or as if they still have that limb not being amputated. And they will also benefit if they take the Neurontin gabapentin from it to relieve that type of pain as well. So these are the case studies, and I'll just leave them for now. We can always go back and provide you with the answers to the case studies, because basically they go over the pathophysiology of pain modulation and pain experience. I have to explain that according to the pathophysiology. Now, next is the temperature regulation. We briefly tapped or went over the fever and how fever develops, and when we said about the infections and pyrogenes, exogenous and endogenous pyrogenes, the bacteria and its toxins like lipopolysaccharides, right? And that's will reset the set point or would change and alter the set point for the thalamus or hypothalamus, and that's when the patient experiences the elevation of temperature. Here we are going to go over different or other types of hyperthermia. So the hyperthermia or temperature alterations in temperature regulation. So the fever is an elevation of normal body temperature in conjunction with an increase in the hypothalamic set point, which is exactly what I just mentioned earlier, and we discussed this, back in chapter 8 about 9 infection and the process and the mechanism how how patients develop the infection based on these exogenous pyrogenes and bacteria, and then how bacteria will release its toxins and lipopolysaccharides, and then these will activate the cytokines like interleukin 1, interleukin 6, tumor necrosis factor, and then eventually they will reset or change the set point for the hypothalamus, and then the fever results. So, or that results in a fever. So the resetting of the hypothalamic thermostat to a higher level in response to endogenous and exogenous pyrogenes. That's fever. And I listed here some of the benefits of the fever, similar to when we listed the benefits of inflammation. We said this doesn't mean that fever is always a bad thing. It's sometimes we look at fever as a red flag or alarming system to tell us, inform us that something is cooking, something is going on, and we have to take an action or to intervene. So these are some of the benefits of fever, and same you'll find also benefits of inflammation in chapter 6. Now, hyperthermia, which is an unchanged setting of the hypothalamic set point in conjunction with an uncontrolled increase body temperature that exceeds the body's ability to lose heat. So hyperthermia, it can be one of the following subcategories like heat cramp, heat exhaustion, heat stroke, and then the malignant is a little bit different. I'll get to that and explain what do we mean by malignant hyperthermia. But hyperthermia, given the definition, it's different than the fever, because there we have specific factors like pyrogenes that are going to change the set point for the hypothalamus. And we have also numbers here about the hyperthermia. So hyperthermia can produce nerve damage. It can also produce coagulation of cell proteins and can also result in death. It can be lethal. It depends, again, on the temperature here, because 109.4, that would result in death. Forms of hyperthermia, we said we have heat cramps, heat exhaustion, and heat stroke. This is another way to explain the mechanism of how fever develop. Pathogens, bacteria, pyrogenes, like polysaccharides, macrophages, cytokines, and then one of the cytokines that very strong to reset the set point for the hypothalamus is the prostaglandin E2. We have too many types of prostaglandin. Prostaglandin PGE type 2, that's one of them. That increases the thalamic or the thermostatic set point, and that results in production of fever. So what's the difference between the heat cramps, heat exhaustion, and heat stroke? Heat cramps, it's common in individuals not used to or accustomed to heat, or those performing strenuous work, exercise, or work in a warm climate. So they're going to lose lots of fluids, lots of electrolytes. So they end up with tachycardia, fever, like hyperthermia, increased blood pressure, and that's often these manifestations would accompany the heat cramps. And that has to be like prolonged sweating and the weight and the loss. Mostly, once they lose the fluid, like water, then they will lose the sodium, and that's what puts them at risk to develop all of these problems. The heat exhaustion, which is prolonged vasodilatation and profuse sweating, and which results in dehydration, hypotension, decreased cardiac output, and tachycardia, because the patient developed the vasodilatation and profuse sweating. And that's which is like a higher level of heat cramps, the heat exhaustion, which is when it's still prolonged sweating and and loss of sodium, but this here when the person is or this results from prolonged high core environmental temperature. So it's kind of highest or higher intensity than the heat cramps. And these are some of the manifestations and when associated with the heat exhaustion. Now, the heat stroke, it's potentially lethal, and the manifestation of that would be edema to the brain cells, or degeneration, which is destruction of the central nervous system. So cerebral edema will be associated with heat stroke. And that would result when the heat loss mechanism fails. The heat loss mechanisms, when it failed, when it failed, so the failure of these mechanisms, which is the heat loss mechanisms, the failure will result in heat stroke. Another manifestation or associated with this heat stroke would be like renal problems, what is called renal tubular necrosis. The rapid peripheral cooling, so we try sometimes attempt to do the peripheral cooling like over the skin, try to cool off the temperature with over through the skin with the rapid method. So the rapid peripheral cooling will cause, it's not recommended because that will result in peripheral vasoconstriction, and that will limit the core cooling. So it's not recommended that we attempt to cool off or to lower the temperature by rapid peripheral cooling in heat stroke cases, because that will result in peripheral vasoconstriction. Because temperature, remember that temperature, the cool temperature result in vasoconstriction. Heat will result in vasodilatation. Like in the inflammatory process, there is vasodilatation. That's why there is hotness and warmth on the affected inflamed part.
I have a question, Professor.
Yes, go ahead.
For that, like, so when you say peripheral, like cooling,
yes,
when
like
you
cold compresses is one of them. Yeah.
When you try to cool through the skin, right? Will the body try like to generate more heat, like to because it's like kind of fighting each other?
Compensation mechanism. It's actually it's the effect will be on the blood vessels to result in vasoconstriction, because you're using the cold temperature. So that's what exactly it does, because again the cold temperature, it doesn't result in accelerating the metabolism. Metabolism would result from the high temperature.
Oh, okay.
Yeah, cold temperature doesn't result in fast or rapid metabolism. Here, it's mostly the resultant effect from the cooling when we attempt to do the rapid cooling. Sometimes we will like we would like the temperature to go like down within like a couple of within like few minutes. So it's better to be done over time, over like an hour or 2 or 3, not over like 5 minutes. So use temperature. We attempt to use the temperature degrees, so we can gradually cool off and reduce the temperature. Otherwise, if you do that in a rapid way or fast way, that will result in vasoconstriction, and that will significantly give us negative results. So the malignant hyperthermia, this one, it doesn't affect all people, but there are specific reasons or causes, and I listed here some of them. There is also, in addition to what we have, accidental injuries, the hemorrhagic shock or major surgery. There is a muscle relaxant usually used in during the intubation and during the surgical procedures and in the OR. We used succinylcholine. It's called succinylcholine. This succinylcholine or scoline muscle relaxant medication to relax the muscles, so that we can do the intubation, the surgeon can do the surgery. So that's muscle relaxant. So patient keep receiving during the surgical procedure. Patient will receive multiple doses of muscle relaxant. This specific medication, it's associated with also with malignant hyperthermia. But those people who are genetically predispositioned, or they have the genetic predisposition to develop that will result in the malignant hyperthermia. So we have to be very careful anytime we use that specific medication that it affects but a small percentage of the population. It doesn't exceed 1 or 2% of the population, but they have that tendency or the genetic predisposition to develop the malignant hyperthermia from the use of that medication, in addition also to the other listed factors here. Okay, let's take the first question. Any volunteers take it? Read aloud and try to answer.
A 54-year-old construction worker collapses at his work site and is brought to the emergency room in a comatose state. His skin is dry and hot, and his rectal temperature is 105. Which of the following is the most likely diagnosed? The heat exhaustion.
All right, so let's take a look at the answers.
I'm sorry, heat stroke.
Okay, good. Heat stroke. Why?
Because he already collapsed.
Mm-hmm. Yeah. So the heat stroke, right? It's the life-threatening
like,
condition resulting from a failure of the heat regulation.
Yeah.
Yeah, because that resulted from the failure of the heat regulation. So it is marked by high body core temperature and the failure of sweating. The heat cramps, which is choice A, they are the result of the loss of the fluid and electrolyte through sweating. Painful cramping and the muscles can occur, but core temperature remains normal. And the heat exhaustion, which is in B, that results from the excessive sweating and the failure to replace the loss, the fluid that is being lost. And that results in hypovolemia, venous pooling, and reduced cardiac output. So in B, if you say heat exhaustion, the skin is wet and the temperature is usually it's normal. Now, and it's not life-threatening, the heat exhaustion. And usually there is a spontaneous recovery when the person is moved to a cool place. It's just moving the patient to a cool place with normal temperature that could recover and resolve the problem. Now, malignant hyperthermia, which is choice D, and that's an inherited, which is genetic condition in which there is an increased temperature when the person is exposed to certain so anesthesia. It could be anesthetics like general anesthesia, or medications like that one, the scoline, the succinylcholine, muscle relaxant drug, or anesthesia. That could result or lead to the malignant hyperthermia, but it has to be like in people who are having that genetic predisposition to develop this. And it has no relationship with the environmental temperature. And then when you say pyrexia, it is a fever, and it's usually defined as a cytokine-mediated increase in body temperature. So it has to do with the cytokines as part of the response to the disease process. And this results in the hypothalamus having a higher set point for the body's temperature for pyrexia, or you can see also a fever too. Next, volunteers.
Which activity has been documented to increase the levels of circulating endogenous endorphins? Stress.
Second.
Pain.
Pain.
All right. Let's take a look at the question. Activity to increase the level of endorphins. When we say endorphins, it's a good thing, right? We need endorphins, so it will block the receptors, and it will result in pain relief.
So it would be sleep.
If you well, in terms of factors, that will be stress. So stress, acupuncture, excessive physical exertion, they have all been linked to increased levels of circulating endorphins. The drinking behavior and cough are actually moderated also by endorphins. Sleep, pain, they are not linked with excessive amount of endorphins. Endorphins will be heavily produced with the or in response to stress. Appropriate term. Next. Other volunteers.
The appropriate term for pain that is present in an area distant from its point of origin is referred pain.
Yes. So referred pain, which is pain that is present in an area removed or distant from its point of origin. And we defined chronic, which is, lasts for long, 3 to 6 months, and somatic, what it is, and right. So acute pain also when it's from cutaneous or visceral or somatic, but it's usually for a short period of time. So it's referred pain. 3, or the next question.
Which mechanism doesn't result in heat loss? The answer is B, vasoconstriction.
Good. So the vasoconstriction is a mechanism that can conserve heat, increase respirations, conduction, convection. All of these mechanisms are going to result in a heat loss. All right, so next chapter talks about the alterations in cognitive system, cerebral hemodynamics, and motor function. So trying, to highlight the most important, concepts and mechanisms in this chapter, like the alteration, arousal, or cognitive network. What do we mean by altered mental status? And the cerebral changes like edema and swelling of the brain cells, and what are the factors that could result in that. So let's start with the alterations in the cognitive network. So two things will, two main components important, significant in order to assess the patient's consciousness. Let's say a patient is poly, semi, unconscious, polyconscious, semi-conscious or unconscious. We can see somnolent, from somnolence, lethargic, right? Or fully conscious. Sometimes we see altered mental status, AMS, right? AMS, which is altered mental status. It's all referred to the consciousness state, which is how the patient's consciousness. So so two components, arousal and the content of thought. We'll say the patient is alert oriented ×3, right? But this is it's not enough. We have to include the arousal and the content of thought. Arousal, which is a state of awakeness, because the patient is awake or semi or fully awake, or there is alterations in the awakeness status. And the arousal, which is mediated by the RAS system, which is not the RAS in the kidneys and blood pressure. This one is the RAS, which is reticular activating system. The An example of how the RAS or the RAS system works, and one of the best examples is that, you know, if you are in the airport with all that noise around you, a lot of noise, no matter where you're at, which airport you're in, which country, there is a lot of noise. Passengers, wheeling suitcases and a lot of noise. Employees and with all of that noise, if they're paging your name, if your name, you hear your name, your name on the paging system, automatically you will be alerted to your name. So that's the all right, the RAS system, it's functioning. So that's one of the functions of the RAS system. So this measures the arousal status, content of thought. So it can encompass all the cognitive functions of the thought processes. Now, why or what are some of the factors that may change that mental status? So when we refer to the mental status, we mean the consciousness, we refer to the arousal, the content of thought. So the change in or alteration of the mental status, which is the altered mental status, sometimes we refer to it as abbreviated as AMS. It could be due to the structural, metabolic, or psychogenic. And on the continuum of the arousal or on the conscious status, we will use like on the continuum, the lowest would be drowsy, like drowsiness, and goes to the other extreme or the other side of the continuum would be like, patient is comatose, unconscious. So these are some of the factors that could affect or change the patient's mental status, structural, and you have some examples here. Infections like encephalitis, patients with CVA, stroke or hemorrhagic stroke, or patients with embolic stroke or brain tumor, or metastatic tumor from another organ to the brain, ischemic changes like ischemic attacks to the brain, which is metabolic in nature, decreased oxygenation, ischemia, electrolyte imbalances, hypoglycemia, and other factors. And then the psychogenic is quite, very difficult to, it's not well or fully explained. And but they refer that to unknown or to some psychiatric disorders or associated with some psychiatric disorders. The coma, either would result from one of the previous factors, or sometimes we induce coma in the ICU. And I will explain why the coma can be induced in the ICU. Let's say a patient experienced or survived the head trauma, traumatic brain injury, or due to motor vehicle accident, patient survived the traumatic brain injury. So in order to stabilize the brain cells and to decrease and to limit the metabolism of these cells, we will induce the patient to go into coma. And by giving the patient, he administers some medications called barbiturate. So that's like phenobarbital or other medications that's going to result in patients be on coma, and patient will be on be monitored like under mechanical ventilation. Patient will be intubated on mechanical ventilation, and patient will be monitored with the EEG, electroencephalogram, in addition to the ICP monitoring as well. So that's the picture of a patient who will be in the ICU under that induced perpetuate coma. And these are the reasons, or we give the drug for the 4 main reasons or 4 major effects. That's the outcome. Why would you induce the coma? Patient in coma, so that there will be a decreased metabolic demand from the brain cells, stabilize cell membrane, which is brain cells. We can decrease the likelihood or the possibility that there is a vasogenic edema, and we'll explain in a few minutes what is the vasogenic edema, which is in the brain cells. We can also produce a more uniform blood supply. So all the cells in brain cells will receive the same amount of blood when we do when we initiate the barbiturate coma. So that's an induced coma due to the injection or the use of drugs like phenobarbital. Breathing or respiration patterns of breathing. We have something called post hyperventilation apnea, and that would affect patients who would have experienced or survived the lower brain stem center trauma, or the neural center in the cerebrum. And the other one, which is more common, you will hear all the time about Cheyne-Stokes respirations, CSR, which would result from the increased ventilatory response to CO2 stimulation. So it results from the increased ventilatory response to CO2 stimulation, and it will result in or cause the hypercapnia. And when we say hypercapnia, which is the accumulation of the CO2. So the changes in the PaCO2, the partial pressure of CO2, will produce irregular breathing called Cheyne-Stokes respiration. The vomiting, which is quite kind of one of the complicated concepts, because vomiting can result from the GI involvement or GI problems. It could also result from the neurological, like traumatic brain injury. And here in neuro, the vomiting, it's associated with the compression or disease affecting the medulla oblongata. Infection, neoplasm, infarction, or the vagus nerve. The stimulation of the vagal nerve or the vagus nerve would result in vomiting. Or the central nervous system injuries. Pupillary changes, which pertains to the pupils, and basically the brainstem area that control arousal, they are adjacent to areas that control the pupils. That's why any brainstem changes will be reflected in the changes in the pupils. And we can tell, or we can infer a lot of data about the changes in the brainstem just from assessing the patient's pupils. What you call in Adult Health 1 or neuro assessment course as PERLA, right? So when so before we get to that, just to make sure that the Cheyne-Stokes respirations, they are abnormal pattern of ventilation with alternating periods of tachypnea and apnea. Like a patient with Cheyne-Stokes, it's not apnea all the time. Patient will have like tachypnea and then all of a sudden apnea, for like, let's say like 10, 15 seconds, 20 seconds. So we call it a crescendo, decrescendo pattern, which is tachypnea and then apnea, no breathing. Because the increase in PaCO2 will lead to the tachypnea in attempt to, get rid of or to balloon off the CO2. But that's the pattern of ventilation and Cheyne-Stokes respirations. Which drugs would depress the respiratory system. And the rate of breathing will gradually decrease until respiratory system could fail. Which medication will be, worried about when you give it to the patient? You should assess the respirations before and during the patients when they, as they receive that medication.
Sedatives?
Right, which is, in other words, you call them opiates. And also you can also, the sedatives, sedative drugs that cause sedation, like one of them is called propofol, right? Propofol is one of them, the sedatives or the drugs that cause sedation. An overdose of these sedatives or the opiates, like morphine, for example, dilaudid morphine, sedatives was like propofol, these can lead or result in a significant decline in breathing rate or heart rate, breathing, and gradually decrease the respiratory, and result in respiratory failure. So anytime you want to give sedation or administer the opiates, morphine or any other opiate, the first thing you would do is to assess the patient's breathing. And anytime you have patients breathing is less than 10 breaths per minute, then you shouldn't give the patient that dose, any opiates or any sedatives. So the neurological assessment, we focus, on the mid-cellular units, just on the awareness and on the pupils, right? But we don't go into what is called the Glasgow Coma Scale. So a change in the pupils, pupillary changes, like for example, the pinpoint and non-responsive pupils, it's not a good sign because that could indicate that there is a brainstem dysfunction. Avoid pupils like an oval shape, which is a midpoint between normal and dilated pupil. And then we have asymmetric and even pupils, like one is dilated, the other one is constricted. That indicates a brain herniation, like there is shifting pressure. There is a shifting on the brain, on one side of the brain. I will explain in a minute what herniation is. So that could be a brain herniation, and that's mostly due to the highlight is going to be due to the increased intracranial pressure. That pressure on one side pushing, the brain to be herniated to the other side. So that's herniation pushing the other side of the brain because of the increased intracranial pressure, increased ICP. The fixed, so that's when there is asymmetric uneven pupils. One constricted, the other one is dilated. Now, fixed non-reactive dilated pupils, that was some refer to it as blown pupils. And it's a poor prognosis, another form of poor prognosis, and that would result also from marked, severe, constant, increased, or elevated ICP. Now, in the ICU, mostly will, or neurological floors or units, you're definitely going to use Glasgow Coma Scale because that's give you more information about patient's neurological system, and the scale, it includes 3 criteria: eye-opening, motor response, and verbal response. And as you assess the patient, there's specific mechanism how to assess every and each item of these under the 3 classifications, and you will get, and then that towards the end you will get a number. 15 is the highest number, which is if you add 4, 6, and 5, that comes out, to that's the 15. That's the highest. That's fully aware, alert oriented, and that's the good number you would expect. And the lower the number, or as the number decreases, then that's indicates that there is a neurological problem. And when the patient GCS or Glasgow scale of I would say 3, then that will be the worst case scenario. Now, for the assessment for the brain cells and to identify what is called the or define or indicate that the patient is experiencing any brain death, and this is something that you will see it in the ICU as they assess for the patients with imminent death or patients with brain death or for anticipated brain death. They will do these tests. So the sake of time, I don't want to go over the mechanism. I mean the exact steps. How would you do the testing? But you can just read from the book. How would you assess for what is called the ocular vestibular reflex, which is a calorie ice water test. And there's another test called, so I'll just leave it so you can review it from the book. And the other one is called so the first one is called caloric test. The other one is Dahl's eye test, oculocephalic test. These two tests are done in the most, I would say, in the ICU to determine if there is a brain damage or brain death. And these are the criteria for brain death. So these are taken from 2 different resources. One of them, the left, hand side of the slide, that's from the IGI textbook, and the other one from a different textbook. Or so 2 different, but most of them, the criteria almost they are the same and very similar. Especially with the glaucoma scale is the STEM 3. That one did not take into consideration the glaucoma scale, for example. The 2 confirmatory would be like the Dahl's eyes, one of them, and the calorie test also. But again, these are 2 different textbooks, so you'll find 2 different criteria for brain death. It's just informational. Now, cerebral death, which is permanent, brain damage is permanent. No behavioral responses to environmental stimuli. The brain can continue to maintain internal homeostasis, like the cardiovascular function, respirations, metabolic function, body temperature. All of these are going to be maintained, but no behavioral responses to environmental stimuli. But the brain can continue to maintain internal homeostasis. Now, the survivors of the cerebral death, they will remain in coma, permanent. They may emerge into either to what is called the vegetative state, wakeful unconscious state, or they may progress to what is called lock-in syndrome. The wakeful conscious state, which is the wake sleep cycle, it's present. The periods of wakeful, and then they're awake, and then periods of sleep. So that cycle is present, but the cerebral function is lost, which is brain cells and function is lost. The eyes would open spontaneously, not in response to stimuli. Spontaneous opening of the eyes. They will maintain breathing and blood pressure patterns, and they will not be on mechanical support, because they can sustain their own and maintain their own breathing and blood pressure mechanisms. The lock-in syndrome, which is described here as that the content of thought and level of arousal, it's intact. But because of the problem with the efferent pathways, it's completely disrupted. So the patient the patient is unable to communicate with us through speech or body language, but the patient is fully conscious. So the cerebral death, or irreversible, when we call it irreversible coma, the death of cerebral hemisphere that includes, is exclusive of the brainstem and the cerebellum. So the brain damage is permanent, and the patient is, or the individuals forever will be unable to recover and or respond to like behaviorally in any significant way to the environment. Any environmental stimuli, patient is unable to respond behaviorally. And then we have dementia and the Alzheimer's disease. So dementia, let's see, what is it? Sorry, agnosia. Yeah. Before that, I skipped this one. Agnosia. So which is the data processing deficits? Problem with, the way how we process the data or information. Defect in pattern recognition. It's called agnosia. One of the tests that we do in mini-mental testing for older adults in like nursing homes, they do one of the questions is to ask them what is that, or how would you define this, which is going to be like a pencil. They have to be like able to identify the pencil as a pencil, clock is a clock. If unable to do that, they have agnosia, and it's part of the mini-mental status assessment form or survey. They do it at the outset, which is admission of all older adults, and that's done for the older adults or residents for the nursing homes. Aphasia, which is the loss of comprehension to communicate with others in language. Dysphagia, which is the difficult or inability to. Aphasia is complete loss, complete, unable to communicate with language. Dysphagia, they are able to talk, but we have different forms. It's disrupted, it's not normal, or within range, or you can call it within defined limits, if you will. But it's disrupted. So it can be associated with, most of the time, it's associated with the CVA, stroke, cerebrovascular accident, and mostly affect the middle cerebral artery, and then the patient will have one of the following. Either that, it depends on the what is the clot or hemorrhage, and the CVA is located. So it depends on the site of involvement in the brain cell or brain tissue. So expressive dysphagia versus the receptive dysphagia, and we have the transcortical dysphagia. The expressive, which mostly had resulted because of the Broca's area in the brain has been affected, blood clot, hemorrhage, trauma. So it's a motor function. The Broca's area reflects the motor function. So the patient can talk, but they have, first of all, they have difficulty of writing, and they will be looking for the words to be used. They cannot find the correct, the appropriate words, to be used at that moment. To say I want to eat, it will take them a while if they're unable to find the words to say it. The 3 words, just I want, maybe I want, or 4 words, I want to eat. So they cannot find the words, and they have a difficulty of in writing things down. Receptive dysphagia, which is more a sensory because of the Wernicke's area in the brain is involved or affected. They are able to talk non-stop fluent, but the words have no meaning. They'll give you a full sentence, but yeah, you won't be able to find out or figure out from the sentence what this the patient's trying to tell you, or what's the message behind it. Just patient's fluent, but meaningless words. Meaningless words. Maybe they can say the words in a sentence, but the sentence doesn't have a meaning. They are receptive. Now, transcortical dysphagia, which will be in like patients with Alzheimer's dementia, they are affected by this, and they have something called echolalia. They kind of repeat the same thing on and on again, just keep repeating the same thing over and over again, and that's called the echolalia. Now, dementia, which is progressive failure of cerebral functions, but it's not caused by impaired level of consciousness. So the patient is fully awake, alert, but they are demented. I've seen patients with dementia in their 40s, but one of them was due to the drug abuse, or overdose, other case was due to the alcohol intoxication or alcohol abuse. So dementia can affect also a younger population, but it's not caused by impaired level of consciousness. So it affects the changes and alterations, the orientation and the memory, language, attention, the intellectual ability will be declined. And that's why you'll see differences or alterations in behavior due to that decline in intellectual ability. Now, the pathophysiology of dementia, it's kind of one of the complex mechanisms and not fully understood, but we can see that the degenerations that would result in or lead to dementia, there is a degenerations that are due to the genetic predisposition, could be some diseases like Alzheimer's dementia or Huntington's disease, HD disease. We'll get to that also in the next chapter. Or progressive dementias produce nerve cell degeneration and brain atrophy, which is progressive dementia, which will result in the degeneration, destruction of the brain cells, and brain atrophy. So that goes under the degenerations and possibilities of the pathogenesis and the pathophysiology of the dementia under the degeneration, like the genetic predisposition, Alzheimer's, Huntington's disease, HD disease, and progressive dementia, and other factors as well, like compression on the brains, on the nerves and the brain cells, or atherosclerosis or trauma. Alzheimer's disease. So the Alzheimer's disease, and sometimes we call it, if the patient is demented with Alzheimer's, and then with dementia, we'll say Alzheimer's dementia. So we can identify that dementia is related to the Alzheimer's disease. The mutations for encoding amyloid precursor protein, one of the theories try to explain the exact, the cause of dementia, even though we know that the exact cause is unknown. And even diagnosing patients with dementia is always done by or performed by the rule of exception, or by exception, which means they have to rule out all other causes of dementia in order to be able to diagnose patient with Alzheimer's disease. And there is no any confirmatory, confirmatory testing or diagnostic test that would confirm diagnosis of Alzheimer's disease, except the autopsy, which means that we can confirm that this patient had experienced Alzheimer's disease, or 100% this patient was diagnosed with Alzheimer's disease just by doing the autopsy. Otherwise, it's just all done by what is called the exception, or by ruling out other causes of dementia. That's about diagnoses. The changes in the brain that would result. So that another part of the theories that would explain the Alzheimer's disease is the loss of the neurotransmitter stimulation of the choline acetylsterase. So the choline acetylsterase, on the enzymes, the brain, the loss of that neurotransmitter stimulation of the choline transferase or acetyltransferase, that's one of the mechanisms that will result in dementia, in the Alzheimer's disease. The proteins in the neuron which become twisted or distorted, that's another explanation how the neurofibrillary or neurofiber tangles, the presence of these tangles, like in the next slide, these tangles or these protein in the neurons that become distorted and abnormal or twisted, the presence of these neurofiber tangles, they found them to be one of the criteria to diagnose patients with Alzheimer's disease. So one of the changes they found in the brain cells, these type of proteins, the neurofiber tangles. And in addition to the also another one called senile plaques, which is some areas of the degeneration, which is like plaque, looks like plaque material, like necrotic tissue. Clinical manifestations, we know patients with Alzheimer's disease, they will have the forgetfulness, emotional upset, disoriented, confused, lack of concentration. They have decline in abstraction. They have that concrete thinking. They cannot do the abstract thinking. They have problem with problem solving, very basic problems. They cannot do the problem solving. In addition to that, they have also a problem with the judgment. Okay, so this question looks at the risk factors for Alzheimer's disease. So what would be a greater risk? Is it in the males or females for Alzheimer's disease? Or
The females?
Females are at higher risk to get the Alzheimer's disease. Right. So we count the risk factors. As we count risk factors, patient B, middle-aged African-American woman with a history of several head injuries. This woman has more than one factor, right? So this woman has the highest factors among the, all the rest of them to be at risk to develop the Alzheimer's disease. Middle age, so that's the age also. And the history of a female and history of head injuries.
So, Professor, I'm sorry
Yes.
if you covered this. I didn't hear you if you did, but
Yeah.
how do you know? When I saw multiple head injuries, I immediately thought this person would get dementia, but I didn't know if we could specifically tag it to Alzheimer's. How do you know it would be Alzheimer's and not some other kind of dementia?
Oh, these are just risk factors. Yeah, we cannot confirm. Yeah, you can confirm that dementia because patients with Alzheimer's disease also they get dementia as well. So they will call it Alzheimer's dementia, but it's just we are counting the factors which would put the patient at high risk to develop the Alzheimer's disease. So when determining who is at at risk, a higher risk, it just remember to start by counting the risk factors. That's all what it's about. What about this question? What's all about? It's about the risk factors. So with the patient with the most risk factors would be B. Is that, did I answer your question, Amy? Yeah. So it's very, even when we get to dementia and adult too, one of the difficult things to to diagnose patient with dementia, given that dementia, its definition, the diagnostic, studies or tools to diagnose it. I will talk about dementia in adult health too, more into diagnosing and all that stuff. But it's for here it's just the disease, Alzheimer's disease, and the risk factors that would put the patient at high risk to develop the disease.
Yes, thank you.
Yeah, thanks. Okay. Okay, I think we approached the end of the lecture, so it's 1:45. All right, so looks like we need another lecture for the neurovascular system. Okay. Any questions?